The guidelines, interesting enough, are a little bit controversial, and they've decided to go back and meet with powers that be, academies, other experts in the field of pain that can maybe clear them up a little bit, maybe put a little bit more of a consumer protection effort to it. And to answer your question, I fear that we may be alienating the valid pain patient because of the hysteria, if you will, that's going on with the use of opiates. I mean, I think it already is. I think a lot of doctors are changing their behavior really for fear of either not feeling comfortable managing these medications, and again, I'm referring specifically to opiates. The fact that the statistics show that they truly have a very negative downside. I think, if I'm not wrong, it's something a little bit over 40,000 people a year that are dying from overdose, which has just surpassed deaths by motor vehicle accidents. So that's an eye-opening statistic. So yes, physicians, I think, are getting less and less excited about doing it. They, may have some certain level of basic training required to use these drugs, and they just may not want to get involved at all because of the liability. That's my fear, and I understand why, because it's killing people. People are dying, and a lot of these people, unfortunately, are not taking these medications as prescribed. A lot of these medications literally come from the medicine cabinet to the streets, and there's a high, value for these medications, so people profit from it as well, and that's part of the problem. We also, which is not exactly clear to me, but I think something that needs to be explored, it turns out that as a whole, our country is very hungry for different substances of addiction that are not just limited to opiates, and I think that has to be addressed as well. I think on a socio-economic level, we need to really focus our efforts on why, as I mentioned just previously, why the American public has such a taste for these medications. So I don't think enough is being done on that level. What we're doing is we're, in a way, scaring physicians from using the drugs at all, and probably scaring patients, so that we're going to go back to the pre-fifth, pain being the fifth vital sign, back in the late 1990s, when the Joint Commission chimed in and mentioned that pain should be the fifth vital sign. The pendulum went from very little opiate use to too much opiate use, and so the pendulum is definitely going to go back that way, so that patients are under-reporting and they're under-treating. I mean, the same thing, and there are very specific pediatric guidelines, and again, safety is the #1 issue. So we would hope that in the use of an expert's hands, that the right people are going to get their pain syndromes treated adequately, and that absolutely involves as a high priority pediatric patients. One of the good things that is out there is access to the drug naloxone that reduces the effect on opiates. I think that might be life-saving to some perspective. Some of the opiate medications that are coming out these days are also in combination put together with other anti-opiate-like chemicals, such as naloxone, as an abuse deterrent. The question to me, and again it's controversial in my own mind, is that are we going to target patients who have an abuse potential? Is that why we're using those drugs? Will it help deter? Yes, because if you try to abuse that drug, for example, try to chew it and snort it, you're going to get withdrawal-like effects. So it will act as a deterrent. I'm just not sure who the proper patient would be to be on those medications. Again, you want to risk stratify to get to treat patients who are adequately at a low risk to possibly benefit from opiate medications. And one of the things that I can tell you that I have seen and that I am understanding with consensus statements from various organizations, highly reputable, highly respected organizations, is that in the non-cancer setting, there is the recommendation that very few people will benefit over the long term, that is chronic term, from the use of opiate medication. So that's eliminating a huge chunk of people when you understand that the statistic of patients with chronic pain is approximated to be 100 million people in this country. I don't believe so, because what this is going to do is kind of sort of readjust things to some perspective so that physicians are either training themselves appropriately and using the drugs appropriately. The message will be sent to the patients that the cases in which they would really qualify for the use of these drugs would be much, much less. Of course, we're not going to alienate the pediatric patient or the cancer patient. There's always going to be the indication to use these drugs in the proper setting. Of course, anybody who has an acute condition, anybody who's come in with an acute abdomen or a fracture or has been in a horrible accident or is in sickle cell crisis, I think the indication will always be there for the use of opiates. It's eliminating that large potential chronic pain group that I think we're now second guessing, do they really benefit over the long term with the use of these drugs, and how much evidence do we have now to even show any benefit, and what kinds of long-term downsides, such as the hormonal axes and immunological side effects and downsides are there that we just don't have enough data to show, or we haven't completely studied it yet. Those things are also brought to question as far as the use of these particular drugs in the long term.